the last of the 3-part series for our senior safety series. I have Hillary here with Apothecary & Co. She's here to present to you about prescription drugs, all about Apothecary & Co. and just kind of educate you on some relevant things. So,
hi, thank you for coming. Which she mentioned, I'm Hillary from Apothecary & Company. So, Apothecary & Company is a pharmacy. We specialize in, number one, we cash, I guess I'm going to say cash medication. I do not accept any insurance companies, but number one, it kind of allows us to offer them at a lesser copay than normal. But then I don't have the red tape of the insurance companies either. Number two, we're a compounding pharmacy, so what that means is we do a lot of bioidentical hormones, we do a lot of pet prescriptions, more personalized medications. So that's the compounding side. And then my passion is kind of educating about drug, as we're going to talk about today, drug nutrient depletions. What are these medications causing on the backside that sometimes, most often, unfortunately, most doctors' offices or either your pharmacies do not tell you. So it's more about empowerment and knowledge, and I'm going to give you the basis for that.
And where are you?
Oh, thank you, pharmacist. So I've been a pharmacist.
But where is Apothecary?
Downtown, right next to Centennial Park.
Oh,
right
okay.
a couple doors down from 501 Diner.
From the restaurant, okay.
Yep. Thank you.
All right.
We're going to talk about polypharmacy. So this is a new upcoming term. So we're going to explain what that is and then the ramifications of that. We're going to talk about prescribing trends, what medications are commonly prescribed, adverse drug reactions, drug-drug reactions, drug nutrient depletions, and then we're going to talk about patient advocacy and empowerment. So polypharmacy, what is it? So the technical term is the use of multiple drugs or more drugs that are medically necessary. So if you're on, say your blood pressure is too high and they put you on a blood pressure medication and it's not holding, it's not working, and your blood pressure is still too high after that, they may put you on a second blood pressure medication. Say after 6 months, 12 months that your medication is kind of still, it's keeping your blood pressure down, but now you've made lifestyle changes, you've made diet changes, you're exercising more. At that point, we need to evaluate if you need to still be on that second medication. Maybe one medication's working with all your diet and lifestyle changes. So at that point, it may be considered polypharmacy. Understand what I'm saying on that? So polypharmacy, the consequences, and I am a very study-oriented person. I've got to have a lot of data to back up what I'm saying. So I'm going to give you a lot of statistics today, but it's more to show the importance of this. So the possibility of an adverse drug reaction, so a side effect, among, and what we're focusing on is the age group of 65 and older, is estimated at 6% of people taking 2 types of medications. If you're taking 5 or more types of medications, the chance of a side effect happening is greater than 50%. It accounts for 28% of hospital admissions currently. It is the 5th leading cause of death in the United States. And death from a side effect is 4th leading cause. So this just shows you that it's very important, but it's going unnoticed. We're not doing the initiatives, whether it be the FDA or some healthcare society. They're not promoting this, and they're not kind of hunkering down on this and showing the importance. So I mentioned that polypharmacy is unnecessary drugs that are not clinically warranted as well. So again, studies, there's a lot of statistics. 60% of people, there's a study, 60% of 236 ambulatory, so just random normal people, age 65 or older, were taking medications that lacked an indication or were suboptimal. So if you're on a proton pump inhibitor, if you're on Prilosec or something like that, and you no longer need it, and you no longer have an ulcer or something like that, that would be not clinically warranted. Sometimes, even if, say you were on Prilosec, you had a ulcer, and you were on 20 milligrams, and you're still having you're still having symptoms, maybe you need a 40 milligram. So underdosing is also part of polypharmacy.
Yeah, you can have a seat over here or over at that table.
If we sit over here, we're looking at with the people. Let's sit. We'll sit here. We'll just turn it around. You can sit here.
I think it's at one end, and then we'll see better.
Okay. Yeah, where is it?
So there's another study that was put out, and it looked at medication appropriate index. So it was defined as a medication without an indication or a purpose. It lacked effectiveness, so again, it's the milligram issue that I just mentioned. Or it was a therapeutic duplication, meaning that maybe it's 2 blood pressure medications and you didn't need 2 blood pressure medications, you only needed 1. It found that 57% of patients were at least taking 1 unnecessary medication. So as I talk about these studies, the commonality between it is always around 50 to 60%. So it's very interesting, the consistency of these studies. There was one more study that was done with the veterans and found that 44% of the veteran population were discharged from a hospital with at least 1 unnecessary medication. So again, it's a lot more prevalent than we think. Those are all ambulatory people. Those are like people like us. But then they looked at this polypharmacy issue within hospitalized people. So in Italy, and again, it's kind of interesting because we're talking about overseas, it's just not United States, it's like almost consistent worldwide. Hospitalized Italian elderly patients had 52% chance of polypharmacy with a mean number, so they were likely to have an average of 5 medications, to be on 5 medications when they were admitted into the hospital. But they had a 52% chance of polypharmacy. So that's very alarming. And then they did one in Austria as well. It looked like polypharmacy. They had a 60% chance of polypharmacy when they were admitted with 8 medications. So the more medications you are on, the more chance of this occurs. In the United States, half of the elderly population admitted to hospitals take 7 or more medications. So again, as you take more medications, the percentage increases, and we will talk about the ramifications of that. So consequences of polypharmacy. We're going to look at what is being prescribed and why. We're going to look at, as I mentioned, adverse drug reactions, the drug-drug interactions, and these are all things that we should be catching as pharmacists. The doctor's offices, well, I should say the physicians prescribing that should be catching it. So the way I look at it is prescriptions the physicians should be like the forefront. They're the ones that are kind of first to recognize these issues. Then if they miss it or they don't think it's an issue, then maybe the pharmacist sees an issue. But these people are becoming more and more, and it's not an excuse at all, becoming more and more busy, and they don't have the time, the capability to provide this consultations or awareness. So I hate to say it, but it almost falls on us. It's almost our responsibility as well.
So these days, isn't there a computer program that when the pharmacist puts in the medication, it'll say, compare it to the other ones that you're taking and say, hang on, you might have a problem? Mm-hmm. There is?
Yes, yeah. So I rely on that. I don't know what the physician, now that they've changed to everything computer, I don't know if their system does that, but as a pharmacist, I do.
Is it MAPS?
MAPS is more for controlled substances.
Usually, excuse me, I have noticed in the last year or two that if I go someplace else to get a medication and I get it at the pharmacist, when I see my doctor, it's on that list. Because I've been, well, how do you know? And
Yes.
so if the pharmacy that you go to is tied into the program, it
Yes.
should be going to your
Well,
primary physician.
yes,
Yeah.
so they have the awareness
So
of
they
that.
have the awareness.
Yes.
Are they paying attention?
Correct.
Right.
But the pharmacy doesn't have the awareness unless, like, if I was to fill a prescription, because I'm not hooked up to that big insurance database,
Okay.
because I'm only cash,
Okay.
I don't have that
Okay.
information. So it's this insurance database that kind of catches
It
drug
takes care of it.
interactions. Yep. But where I come from is I make sure what medications are you on. It is my responsibility to, what are medications are you on, and, have that conversation. So, prescribing trends. It's very interesting to know that 58, this is everyone over the age of 65. So this is the top 10 chronic conditions. So when I look at chronic conditions, these are the medications that most likely fall under this polypharmacy issue. So 58% of 65 people, age 65 and older, have a high blood pressure issue. 47% have a high cholesterol issue. 31% arthritis, 29% heart disease, 27% diabetes, 18% kidney disease, 14% heart failure, 14% depression, 11% Alzheimer's and dementia, and 11% COPD. So when I look at issues or certain drug classes that we need to focus on for this issue, we're going to focus on these. And further in this talk, we'll dive into certain medications that fall under these categories too. So it's interesting to know that 44% of men and 57% of women take 5 or more prescriptions and or non-prescriptions. So that would be over-the-counter medications too, because I cannot leave those out. Those are very important, per week. So on average, it kind of goes, I dare say that 65 years and older, your average prescription count is 5 to 7 pills. Would that be, with the show of hands, without being too nosy, is that true for you guys? Taking 5 or 7 more prescriptions a day? No?
Do vitamins count?
Vitamins count?
That's me.
So it's, it brings awareness. 12% of those people, that group, takes 10 or more prescriptions. So, I mean, as a pharmacist, I see it. Maybe not where I am now, but where I practiced previously, a lot of people had 10 prescriptions or more. And we'll go into showing that then you're more at risk for side effects and adverse drug reactions and drug-drug interactions, so we'll talk about that in a minute. So now that we know this bucket of chronic conditions that we all have, we know if we break that down even more, 23% of us are on a diabetic medication. 25% are on a beta blocker. Beta blockers are heart failure medications and blood pressure medication. And then 50% is on a cholesterol lowering medication, such as a statin. So that's half. Half of us are on a statin. So even more so, we need to dial into those medications. So drug-drug interactions. When I was first a newbie pharmacist, I don't want to say I was practicing with ego, but I was naive. And it's kind of shifted because we're more, I believe in more personalized medication or medicine. So I believe that everyone, if I give you, each one of you, the same medication, you're all going to react differently. You may have a different side effect. You may have a different outcome. Is it going to decrease your blood pressure? Is it going to increase your blood pressure? Everyone's going to be different. That's why I practice with more of a personalized, individualized approach. But I'll give you an example. So a person used to come to me and say, I need a brand name medication. Let's just say there's Tenormin and atenolol. Tenormin was the old brand name medication for our blood pressure medication. The generics, atenolol. They come to me and say, I need Tenormin. I cannot tolerate atenolol. The old me, 20 years ago, would say, no, it's all the same medication, you're crazy, right? So now, they've kind of identified this. There's type A adverse reactions, which 80% of us, if we have an adverse drug reaction or a side effect, 80% of us have this kind, where it's more, maybe this blood pressure medication took your blood pressure down too low, or maybe it caused hives or something like that. That's type A. Type B is bizarre or idiosyncratic in nature, so it's all in your head. So now, 20% of us have that. The more fillers, the more changes they make to these medications now. I mean, a lot of population now is gluten sensitive. A lot of these have gluten. A lot of these medications have corn fillers in there. So that is the all in your head population that I like to help. Those are my people that I like to figure that out and get an individualized approach. But it's nice that they recognize that now in type A and type B. So it is reported that 35% of older adults experience an adverse drug reaction each year. 29% of those people require hospitalizations because of that. In 2005, and this is the most updated statistic I could find, in 2005 there was 4.3 million adverse related healthcare visits in the United States. And I can't imagine that's got to be almost doubled now. So adverse drug reactions is an issue. Now we move on to drug-drug interactions. Drug-drug interactions, I'll give you an example. There's a blood pressure medication called spironolactone. If you take that with any potassium supplement, or potassium itself, a potassium tablet, your potassium can become too elevated and then cause some heart issues. So that would be a drug-drug interaction. That is something that the doctor should catch, and that's something that the pharmacist should catch. Maybe your potassium runs low anyways because you're on a diuretic or something like that. And if you could tell me that, then we could have that conversation. But it's my responsibility to bring that up to you and say, you know, is this normal? Did you and your doctor discuss this? From a herbal side of view or point of view, and more from a over-the-counter point of view, there's an herbal supplement called St. John's wort. Very common. They'll use it as like an antidepressant. If you take that with any sort of blood pressure medication such as verapamil, amlodipine, calcium channel blocker, those two interact. So it's very important to be transparent with the physician as well as the pharmacist to tell them what over-the-counter medications and supplements you're taking too, because there is a big correlation with drug-drug interactions or drug over-the-counter interactions with that too. So if you're on 5 or 9 medications, 5 to 9 medications, you have a 50% chance of a drug-drug interaction. There's one statistic out there that says 20 or more medications increases to 100%. I pray that no one's on 20 or more medications, but I did find a study out there that said if you're on 8 medications, one did report that there could be a 100% chance of a drug-drug interaction. So drugs. Now we're going to talk about drug food. Most notorious is grapefruit. If you're on a statin, if you're on amlodipine, a calcium channel blocker, there's going to be a warning label that says do not, or it should have a warning label that says do not take with grapefruit. What it does is that the grapefruit kind of stops your body from breaking down the statin. So your statin medication levels increase in your body and stay higher at a longer period of time, creating more side effects. So more chance of muscle aches and things like that. So, I mean, besides drug, we need to bring up drug food. Another one is some antibiotics. You cannot take, let's say, ciprofloxacin or levofloxacin for if you have like a chest cold or pneumonia. You cannot take that with any iron or calcium or anything mineral-wise. Otherwise, it binds to the antibiotic, and the antibiotic doesn't work. So I guess what I'm trying to say is read those warning labels, and you'll be informed at least that way. my favorite, drug nutrient depletion, because this is something that pharmacists, I had to take extra training and extra courses, this is what I dive into that I did not learn in pharmacy school. The doctors are not learning in their, in medical school either. So we can get drug nutrient depletion. So what that means is if you're taking a medication, it's depleting in various reasons that we will cover real quick, the amount of vitamins you are getting in your body. So you can get drug nutrient depletions from diet. So what in the 1950s, if you look on any labels, whether it be food, supplements, vitamins, you'll see RDA, recommended daily allowance. And then it will say the vitamin C in this product is 100%, the vitamin D in this product is 20%, or folate in bread is 5% of your daily allowance. Those values are based on the 1950s. It has never been updated since the 1950s. Our soil content has decreased. It's not as nutritious or nutritive, or it doesn't have many minerals in it as it did in the 50s. Our fruits and vegetables are deficient in it as well. I think there's, if you take spinach has, I want to say maybe 30% less iron in it than it did in the 1950s. So that calls for, this isn't me pushing supplements and vitamins on you, but it's more to bring the awareness that our food no longer nourishes us as it did in the 50s or earlier. You throw on medications on that, and when the medications start depleting it, then you're going to be further depleted, and then there's going to be ramifications for that, and we'll hit on some examples in a minute. Nowadays, we're also looking into genetics. So some of us have, I don't know if you've heard this, but there's called genetic SNPs. So it's the MTHFR gene mutation. So if 30% of us, if we eat bread, we can't take the folic acid out of that bread and use it in our body like we normally would. There's a genetic component that allows us to break down folate or folic acid to its most usable form in our body. And some of us are missing this gene component. So now we're looking into genetics in this whole mixture. Another thing is absorption issues. As we grow older, our body can no longer absorb things through our intestines as we did when we were younger. We make, as we get older, less stomach acid. We need stomach acid to absorb lots of vitamins, specifically B12. And then nutrient depletions from poor quality supplementations. In my pharmacy, I sell, a lot of the brands that I sell are, I've got to have a pharmacist license to sell them. I've got to have some sort of medical license to sell them because I know that they are not filled with any fillers. It's bare minimum fillers. I know that they're therapeutic amounts. A lot of my supplements and vitamins are already broken down into the most absorbable form. So I've got I should have brought it, but I have a picture of a person with their stomach and colon and intestines, and they took 3 Centrum Silvers, 1 each day. Not one of those tablets were broken down. When they checked via x-ray on the 3rd day, they were still stuck, not dissolved, just in one big lump. So it comes down to being able to break it down and absorb it too. Excuse me.
I have been told that when you do get something like that, to at least put one in a glass of water and see how long it takes to dissolve. And then you know what goes on in your stomach.
Exactly.
Right?
Yeah. Yeah. That's a good idea. So why should we address this? Why is this an issue? I mentioned the reasons: food, diet, genetics, things like that. But it was very interesting and eye-opening to me, and this is an older study, I haven't found anything more recent, but in 2009, it was determined that 85% of the population was deficient in vitamin E, 75% of us were deficient in folate, 70% were deficient in calcium, 70 to 90% were deficient in magnesium, 55% were deficient in vitamin A, 45% deficient in vitamin C, and then 42% were deficient in zinc. And what goes on to say that there was some iron, copper, B12, other vitamin B deficiencies, but that was very eye-opening to me. I wouldn't have thought that it was that drastic in the higher 70s and 80s. So the top 10 prescriptions written in 2010. And I'm gonna go over these and then we're gonna hit on this little sheet that I have right here on the drug classes and then what they deplete. So when we look at the commonality with our chronic conditions, the commonality with those top 3 medications that were prescribed, the anti-diabetics, the beta blocker for blood pressure, and then the statins, they're gonna fall on this top 10 prescription list. So hydrocodone, which is the Norco combination, is on that list. That depletes glutathione. Glutathione we need as a liver regenerator. It's a master antioxidant. It keeps our liver in check. It keeps almost our metabolism, our drug metabolism in check. Hydrocodone combined with acetaminophen, the Tylenol, depletes glutathione. Second one is simvastatin. That depletes CoQ10. That's the number one, and I think most doctors have that in their brain, and so do the pharmacists. But if you're on simvastatin or any sort of statin, you should be on a CoQ10. That alone depletes CoQ10 reserves, which you need for your heart, for any muscle energy. It's an antioxidant. It depletes CoQ10 by 30 to 40%. As you age, you're depleting it even further. So by the time you're 70, 80 years old on a statin, you're depleted by 80% already. So that is a huge, that's for energy, for your biggest powerful muscle in your body is your heart. So it's very important to supplement with CoQ10. If I keep on going down that list,
Sorry, can I just stay on that? Because what you said affects us on statin. So you're saying that I would have to get, a tablet that gives you CoQ10?
Correct.
Okay, so the doctor should have recognised that.
A lot of them are now. Some don't, but that's probably the number one drug nutrient depletion that they are recognizing right now.
So is there when you have your blood work done, is
Nope,
that
it's
test?
just, you don't really need a test for it, it's just assumed.
So how do you know you need it?
Because it's documented so much. As you age, we know that you're going to become deficient, your body no longer produces it, but when you add that medication on, it just sucks it up. So that's one of the things that you don't have to test for, it's just assumed.
Okay, thank you.
I mean, I believe there are blood tests, but number one, I don't think insurance would cover it. Number two, it'd be just more of a waste of money. I put on there what each one of these vitamins and nutrients do for you. If you have an ulcer or something like that, I mean, you don't want to have an ulcer eating away. So it's a fine balance. At that point, we need to be transparent and have the responsibility to let these pharmacists know on the medications that we may be taking. The thing with statins, like omeprazole, it's a slow taper time. That's what I'm here for. I will give you all the time that I have. It's my job. So from a personal point of view, I think that's my responsibility, but.
So I really need to go back and say, do I need to be on it now? And